Let's study hypertensive disorders in pregnancy. According to IHSSP, that is International Society for Study of Hypertension in Pregnancy, categorizes hypertensive disorders of pregnancy into 5 main categories. That is, one is gestational hypertension, second is preeclampsia, third is chronic hypertension, fourth is preeclampsia superimposed on chronic hypertension, and fifth one is eclampsia. Let's study one by one. First is gestational hypertension. Gestational hypertension can be defined as hypertension which is developed during the pregnancy for first time. Defining criteria is BP more than equal to 140/90, measured at 2 occasions and 4 hours apart. Basically, how to measure BP? BP should be measured in the sitting position in right arm at the level of heart, and the cuff should be encircling the arm at least 80%. Gestational hypertension, that is the hypertension which is developed during the pregnancy for the first time, and BP is more than equal to 140/90, and it is usually seen after 20 weeks of gestation, and BP comes to normal values after 12 weeks postpartum. Gestational hypertension is not associated with end organ damage or proteinuria. Second is preeclampsia. That is important. How to define preeclampsia? Preeclampsia can be defined as BP more than equal to 140/90, but also associated with proteinuria. So, how do we define proteinuria? Proteinuria is defined as more than equal to 300 mg of protein in 24-hour urinary sample. Basically, what we do, we ask the patient to collect urine for 24 hours in a container, and then we send it to the lab, and if report comes out to be more than equal to 300 mg in this sample, then it is considered as proteinuria. But as collection of urine for 24 hours is a tedious process, we can also use random sample. In that more than equal to 30 mg in random sample will be the defining criteria. And also, dipsticks are easily available. So if it is more than equal to +1 on dipstick, that will also considered as proteinuria. So can anyone tell more than equal to +1 represent how much amount of proteinuria? That is 0.3 mg per deciliter. So these are the key points to remember. But we can also define preeclampsia without proteinuria. As I said above, that preeclampsia is associated with proteinuria as well as end organ damage. So if preeclampsia is existing without proteinuria, it means that end organ damage will be there to define the preeclampsia. So there are 5 key points which we need to remember for end organ damage. One is LKFTs. That is serum creatinine more than equal to 1.1 milligram per deciliter. Basically, we say that there is doubling of the baseline creatinine value. Second is LFTs, when there is doubling of OT and PT. Normal value of SGOT and SGPT is around 40. So if there is more than equal to 80, then we will define as end organ damage. Third is preeclampsia also affect our lungs. This will be seen in the form of pulmonary edema. Fourth is also affects our CNS, which will be seen in the form of headache and visual symptoms. Last is decrease in platelet count, that is 1 lakh. I will be describing all the end organ damage with the logics in the next slide. So basically, what are the risk factors for preeclampsia? Risk factors of preeclampsia can be divided into the factors which are high risk and factors which only increase the risk. High risk for preeclampsia is if there is previous history of preeclampsia in previous pregnancy, then it will increase the risk of preeclampsia in the present pregnancy by 60 to 70%. This is the important we should remember. Second is if patient is already having chronic hypertension, then it will be a high risk factor to develop the preeclampsia in this present pregnancy. If patient is already suffering from diabetes mellitus, if patient is known case of renal disease, if patient is already having anticoagulation disorder, that is APLA, antiphospholipid antibody syndrome. Now, other arm which includes the factors which only increase the risk. One is increased BMI. Second is extremes of maternal age, that is teenage or elderly age. Next is molar pregnancy. Next is multifetal pregnancy. Certain other factors include ART. As we know, in today's time, assisted reproductive technology is increasing, so as the risk of preeclampsia is also increasing. And also preeclampsia is usually seen in the primaries, as there will be first time exposure to chorionic villi. Also, if there is excessive exposure to chorionic villi, it will also be a risk factor for preeclampsia. Excessive exposure means either it is multifetal pregnancy or gestational trophoblastic disease. Then there will be increased risk of preeclampsia. Usually we say that smoking is a protective factor for preeclampsia. Protective factor for preeclampsia. This is important. Next is pathophysiology of preeclampsia. First is whenever there is altered immune response to the paternal antigens. That's why the preeclampsia is increased in case of primaries or primary paternities. Whenever there is exposure to the chorionic villi for the first time, then it will lead to increased risk of preeclampsia. Second is if there is absent vascular remodeling. This concept is very important. Whenever there is absent vascular remodeling, there will be uteroplacental insufficiency that is leading to placental ischemia. How do we define that there is placental ischemia? usually during the pregnancy there is increase in PLGF, that is placental-like growth factor, and there is also increase in vascular endothelial growth factor. Both these factors are the angiogenic factors.